To today's webinar. Thank you for joining us as always. Today we're going to be talking about your seating assessment for your moderate to maybe more simple clients. That's what we're aiming this for. Tilly's going to jump on screen just to say hello. She's helping behind the scenes.
Hi everyone.
And she'll also be helping us with the mat. So this first bit we'll do some didactic stuff, make sure that we're all on the same page, and then we'll do some hands-on practical stuff. So remember that we have some must-haves, some fundamentals, that, things that we absolutely need to do, whether we're talking about a prescription for, I don't know, a bedside chair or a manual chair, a power chair. We really need to protect the skin. Talk about how you protect that in just a moment. And then we also, especially as we get older adults, we want to think about protecting that physiological functioning. So breathing, swallowing, elimination, all those vital organs need space to move. So as our postures maybe get a little bit more complicated, we'll want to make sure that not only are we protecting the skin, but we're also protecting that trunk space so that the vital organs can do their job. And then also with an eye on the future, we want to make sure that we're preventing any worsening of deformities, worsening of asymmetries, pelvic obliquities, scolioses, forward leans, that sort of thing. Remember that we live on planet Earth and gravity is always affecting us. So any small little curve now, you look at it with gravity 5 years later, it'll probably get bigger, okay? All with the idea of making sure that people have more functional capabilities and they're comfortable using the equipment that we're suggesting. That's what I am really thinking of as good enough posture. That we're promoting function, we're promoting comfort, while also protecting the skin and protecting that physiological functioning. Then when we think about, sort of protecting against skin breakdown, we want to create a risk profile for our clients. It says we're muted. Sorry, guys. Hey, Tom, can you give us a heads up? Are we good? Everybody says we're live. Sorry. All good now. We got other people behind the scenes. So thank you, Tom, and apologies, guys. I will go back just a smidge. Sorry. Really, we have sort of these aspirational goals. We want to promote function. We want to make sure the equipment that we're prescribing and advising is comfortable, while also making sure that we're protecting the skin from skin breakdown, from injury, and also that we're promoting that physiological functioning. That all happens in the trunk space. So making sure that they can breathe properly, that they can swallow properly, food can get into their digestive system and leave their digestive system. Okay. All while making sure that we're looking ahead. We live on planet Earth, there's gravity, it's going to worsen any small asymmetry. So just make sure that you're preventing those from getting worse and really getting detrimental. So we think about protecting the skin, we're really protecting it from pressure injury, which is about weight and pressure distribution. We're protecting it against shearing forces. Remember, shearing is stretching or sliding forces, and that actually influences a bigger area and also reduces our ability to tolerate pressure. So sliding forces, we need to manage those. And then we also have to think about heat and moisture that's seating in our face. Those are the main culprits of breaking down our skin. So when you're first looking at the client, even before you get into their postural assessment, I want you to think about what's creating risk, create a risk profile for them. And, there's lots of different things that go into this, but I think if you know the answer to these sort of 6 common culprits of skin injuries, you're going to be a long way. So I always ask, hey, can they do a pressure relief? Will they do one, a good one? So they're taking weight off of those bony areas. Do they have abnormal or absent sensation? So they're not getting the triggers to move. they don't have sensation, they're probably less likely to fidget around. Again, putting them more at risk for skin breakdown. The longer they sit, the more at risk they are. So how long do they typically sit throughout the day? Are there breaks? Are they getting up to get a glass of water? Are they, if they're using their chair all day long, are they using their power seat functions appropriately? Asymmetric postures. Are they sitting heavy on one side? Are they sitting really slouchy so that they're not putting their weight through pressure tolerance areas? Okay, so I call this sometimes goofy postures, just uneven weight bearing throughout the pelvis, maybe even the back. And then do they have some prominent bones? Maybe they've lost a lot of muscle belly, they're on the skinnier side, or again, they're sitting asymmetrically. So they're sitting heavy on one IT, or maybe even a GT, or they're sitting with a very pronounced posterior pelvic tilt, and they're sitting more in their sacrum, their coccyx, than their hamstring muscle bellies. The #1 sort of risk factor is a previous history. So make sure that you're asking, hey, has there been an incident before on the seated surface of some sort of injury? And do they know what it was caused by? And how did it heal? And maybe even, hey, can I take a look at it? Okay, so those are what I call my primary risk factors for skin breakdown, for injuries, either pressure or shear related. And then we want to break down this assessment process into really 4 steps. Okay, that way we create sort of a roadmap about where we want to go and where we are in the whole assessment process. First thing, especially if they're already in a wheelchair, is think about their current posture. What do you like? What are you worried about? Realize the things that you're worried about are going to be primarily things that put the skin at risk, that put that physiological functioning stuff at risk, and reduce their sitting tolerance and reduce their comfort. Okay. Look for areas of high pressure. Look for areas of shearing or sliding. And then triage that again. What are you most worried about? Also ask them, what do you like about this wheelchair? What's the best thing about this wheelchair? What do you not like about this wheelchair? If you were to get a new wheelchair, what 2 things would you keep? What are the 2 things that you'd like to get rid of the most? Okay. Also look at the chair. Is it really clean and pristine, hardly looks like it's been used at all, or it's being very well maintained? Or does it have the last 6 months of dog hair and fuzz in the casters and the spokes? Okay. Is one side really scratched up versus the other? It just gives you an idea of how this wheelchair is being utilized. And then sort of the last part of this, it's going to be more if you're more complex, probably full-time wheelchair users, is about the postural tendency. Do you find that they're tending to go a certain direction? Are they tending towards flexion collapse? Are they tending towards their right side or their left side? Okay. Are they tending towards sliding? And then think about, do you have a high tone problem or do you have a low tone problem? Because really when you think about these tendencies, when they're not supported, that's where they're going to go. Or when they get fatigued, that's where their posture is going to end up. So you can offer supports towards, alleviating that postural tendency. So I was thinking, hey, do I have a tone problem, a high tone problem or a low tone problem? Do I have a flexion problem? Do I have an extension problem? Do I have a rotation problem? And they could have all of those, right? Get your information here about how they're currently sitting. If they're not using a wheelchair, you can do the same process during your sitting assessment. When you're doing a dynamic balance check, where do they go? Do they tend towards flexion and posterior pelvic tilt? Do they not have balance there? Or do they tend to really lean to one side? And that's what we mean. We're just looking at what's going to happen to that posture when they're tired or when they're not supported, so that you can make sure that you're building in supports correctly and accurately. So here we're just looking at a couple case examples. This is a C5, C6 quadriplegic. He's been hurt for quite a while. I would say his postural tendency is towards flexion. He has a low tone problem. Gravity is really influencing that. And that's leading him to skin integrity issues because he's putting a lot of pressure through his sacrum, his coccyx. You can also see that he's got a very diminished sort of pulmonary space there. So this sort of collapse is reducing his ability for an effective cough, so he can't clear his secretions. It's also limiting his lung capacity. It's really putting him at risk for probably pneumonias or respiratory sort of issues, apart from the skin integrity issues. Okay, so we want to think about, can we bring him up? Can we create extension? Can we create a more neutral pelvis with him? Okay. Remember, when we're looking at our assistive technology, we're going to look at the shapes, we're going to look at the orientation of the wheelchair and some of the angles to help us. But, you know, we're at Seating Assessment 101. We're just trying to figure out what we want to create, not quite yet what tools we're going to use. Here, this is Thibaut. He has sort of the opposite problem. He has a high tone problem and towards extension and rotation. And although it's very tempting to say, oh my God, my priority, you know, is the head, what kind of headrest can I do to fix this? We know that a head problem like this really needs to be sorted, or at least assessed at the pelvis first. Because I really need to get that tone reduced, moving towards flexion, create more forward head opportunities before I can address that. Okay. But as his problem list, number one would definitely be that head position. Sorry? I'm not seeing slides. Wow. This has been really one of those crummy sort of days. That's okay. You guys didn't miss anything except for one picture. Only this guy. So we'll start here. Okay. Sorry, apologies. That's completely my error. We were worried about Sam. But you didn't miss anything except for one picture. Oops, going the wrong way now. This guy. And so this is Thibaut. He has a little bit of a different problem, extension. Sliding out of the chair is probably going to be his second sort of problem, okay? Where we need to protect against shear forces, pressure relief sort of issues. Best thing for him is going to figure out what kind of range of motion he has, what's available, and that's going to happen from that supine assessment. Okay, so we'll look at how that works in here in just a minute. Ray, he's really having a sliding sort of problem. He's got a traumatic brain injury. He's sliding out of the wheelchair, so he's not getting very good pressure distribution. He's also, you can see, a little bit oblique. We've really impacted his trunk space, so that it's hard for him to clear secretions again as well. We have pressure issues, skin integrity issues. Okay. Some other stuff here, AFOs. Trying to keep his feet a little bit into neutral, plantar flexion. And then the staff is having trouble keeping his feet out of the casters. And so that's what sort of that webbing is there. But really when we address or we look at what's happening here, we're just having trouble keeping him in the chair. He's sliding, his feet are wanting to get underneath the chair, okay? So can we, again, he's gonna be a guy that we really need to do that supine assessment and see what's possible within his body. But here in that step one, all we want to do is create a problem list. Here, instability, sliding, creating problems, trunk space, and lots of pressure and shear forces at his bottom. You do see a little bit of pelvic obliquity. So he's heavily weight bearing on this side. And Marty also has a traumatic brain injury, quite a few years here. Again, we've got a big head problem that's going to be tricky to fix. This is, you know, really where you want to put, you're going to want to put your hands up here, but start at the pelvis because the pelvis is the foundation. Again, another guy where we want to get him out of this chair and figure out what's actually going on, what ranges of motion are available. For his problem list, definitely head position. He's having trouble swallowing, clearing his own secretions. You can also see that there's a big scoliosis here. So left side, his left-sided lungs are really going to have trouble expanding. And we also have a difference in weight varying left to right. Okay. One more sort of another complicated situation, because he's a double amputee and also has had a pretty complex stroke. So this is Carlos. He's in sort of a water princess chair. Doesn't have mobility, and he'd really like to be able to move himself around, and he lives in a facility. So we need to look and see what sort of ranges of motion are available, what kind of device would give him hopefully independent mobility. You can imagine on this sort of princess chair here, he has enormous sliding forces. He doesn't have good weight distribution because his stumps are so small or so short. And also, again, no independent mobility here. You're going to create that problem list. Put the most important issues at the top. The most important issues are going to be skin integrity, so pressure issues, any tone, sliding issues, comfort issues. And then try and figure out what their postural tendency is. Low tone, high tone problem, flexion problem, extension problem, rotation problem. Making sure at the end of the day that we're making attainable, sustainable posture, not only for the client, but also any of their caregivers that might have to help get them into this posture. That's going to go into both the stability and the comfort factors there. And then step two. Step two is going to be your supine med assessment. And for your part-time wheelchair users, for your less complex clients or clients that you already know their strength or range of motion quite well, you may skip this step entirely and just start with your sitting assessment. Okay? But for a lot of these pictures, the case studies that I just went through, really valuable to go through your supine assessment first, because it gets gravity out of the way. Gravity is no longer working against you. It's much easier to figure out what postures are available, what ranges of motion are available, what corrections you can make. I always think of that supine assessment as what's possible versus your sitting assessment is, okay, what's practical to do? When you're in your supine assessment, this is a great opportunity to look at their skin integrity, any issues that have been problematic in the past, any red areas now, any open areas now. Try and figure out what's caused them. Is it a pressure thing? Is it a shear thing? Is it a moisture thing? Okay, or even some ones that have healed up. And then the next thing you're going to do is try and correct any of the asymmetries that you saw in their wheelchair or in their seated posture. Try and correct them. Start at the pelvis. Remember, we're a biomechanical chain. Stuff at the pelvis is going to influence up and down that biomechanical chain. Okay, think about 3 ranges of motion. Think about your flexion extension. Think about your side bending, really, in your frontal plane. And then also think about rotation in your transverse plane. You'll want to start at the pelvis, but when you're moving the pelvis around, you'll definitely want to see what effects it has on the trunk. When you sort of neutralize that pelvis, let's say you had a big posterior pelvic tilt, and you move that into neutral, but all of a sudden you get a whole bunch of side flexion, you may not want to make that correction because now you're taking away lung space. Okay, so move the pelvis a little, around, try and bring it towards neutral, but definitely consider the effects it has on the trunk position, on the head position, also its effects on comfort, on maybe any sort of tone or spasticity, any fear that might be being created by your client. Okay. And then go up and down the biomechanical chain. Then look at the spine. Can you correct some asymmetries that you saw there? Go up to the head. Can you then correct any asymmetries? Again, looking at all 3 planes. Looking at sagittal plane, looking at frontal plane, and looking at the transverse plane. Then we'll want to look at the range of motion that's available once you get that pelvis and the trunk and the head in a pretty good position. We're most concerned with hip flexion, abduction, adduction, within that range of hip flexion that you'd like them to maintain. Same thing with internal, external rotation. Okay, in the amount of hip flexion that they're going to sit in. Then we want to know how much hamstring length we have. Hamstring length with the hips and the amount of flexion that they're going to sit in. And then onto the dorsiflexion, plantar flexion, inversion, eversion of the foot. Okay. And you'll do that for each side and see what's available. Here again, this is Tebow. We get him onto the mat table, get gravity out of the way. We see the same sort of asymmetries. We're going to want to see, hey, can we bring those knees into midline? What kind of hip flexion do we have? What kind of hip flexion do we have without further rotation or extension issues with the trunk? Okay. Can I give a little bit of rotation at the hips in order to get back some rotation, some midline of the trunk? And once you do that, hey, where can that head come? And also with Tebow, remember he had an extension, sort of high tone problem. I want to think about how I can relax his tone so he's not always coming back into that extension. What positions, what postural supports slow down or reduce his muscle activity. A little bit of an easier case here. This is a young little boy with spina bifida. You can see that he's got a pretty significant pelvic obliquity and even in supine, a pretty significant scoliosis. Okay, so let's start at the pelvis. Remember, start at the pelvis in all three planes. I tend to start with pelvic obliquity, and then I'll look at rotation, and then I'll look at posterior anterior rotation. If you can find the ASIS and PSIS, great. If you can't, try and find the iliac crest. If you can't find that, use your inspector goggles and imagine where that pelvis would be and look for the clues like a waistband, wrinkles in the shirt to try and imagine where neutral pelvis would be. For him, it's pretty easy to find his ASISs. So we've put thumbs on both those ASISs, and you can see that on his left side, he's quite a bit lower. I would call that a moderate to severe left-sided pelvic obliquity. It's hard to see in my two-dimensional picture here, but he's also just a little bit deeper, towards the mat table on this side. So he's going to have his left side back and his right side forward. Okay. And then on top of that, he also has a pretty significant scoliosis, convexity, so the bigger curved side on his left. I'd also call this a C curve because his shoulders are significantly out. So what we do at this point, try and move that pelvis, try and get those two thumbs in alignment, top to bottom, and deep to shallow, if you will. Okay, see if you can get it there, not at the expense of his trunk. Okay. Get that pelvis there, and then try and straighten out his trunk. Okay. Some of those muscles might feel really, really tight for him. Okay. And that's exactly what we did. You can see here, we're nice and neutral, close enough really, and also sort of deep to shallow as well. And then here we can straighten out that trunk, and so that we know that we're going to be able to create that reduced posture, which is really important. He's about 5 years old in these pictures, so very important that we're able to try and give him that postural support now before these asymmetries become really fixed. Okay, when you're looking at that supine assessment, it might be really useful to look at the pelvis, move it anterior, posterior, see what feels sticky, what feels loose, what won't move at all in those three different dimensions. Don't forget that we want to make sure that we know what's happening at the trunk and at the spine. And if you can get in there, I typically will put my hands on that pelvis and give it a little bit of movement. Again, I'll show you with Tilly here in just a moment. Anterior, posterior, look at that lateral excursion, that's what I call this. Can you neutralize it? Can it move? What feels sticky? What feels loose, really mobile? And then also in that transverse plane, in terms of the rotation, what can move? Can you get it neutral? Make sure that it's not creating bigger curves at your spine. And then again, you want to make sure that you're checking the range of motion that's available. If we have reductions in hip flexion, we can make modifications to our cushion, to our seat to back angle of the wheelchair. If we have reductions in hamstring length, we can make a change to the front end angle of the wheelchair, the hanger angle, or even possibly the foot plate position. Okay. If we have problems with dorsiflexion, plantar flexion, we can also make angle adjustments to the foot plate. And here's Carlos. He was the one that was in that water chair, that princess chair. Said he wanted to go back to a manual chair and sort of being able to move around himself. He actually had a one-arm drive wheelchair in the past. And I was very concerned that he wouldn't have the range of motion in his hips, nor would he have the trunk stability to allow that to happen. The best way to check that is really to get him onto the mat table and just take a look. I did it in supine because then it's safer. I don't have to worry about giving him trunk stability at the same time. And with him, I really needed to see 90 degrees of hip flexion for this to work. Okay, so indeed, 90 degrees. And there in those pictures, you can see that his stumps are quite short. So we are going to have to really worry about sort of pressure distribution to make sure that we can keep his skin healthy. If you are looking at client for their range of motion with full legs, here's a nice example. Looking at the amount of hip flexion that's available. Try to keep the non-tested leg bent for you because it's not going to pull the pelvis on the opposite side. So sort of cradle that into your body while you're testing the opposite leg. And remember, we want to see how the femur is moving in that pelvis and the acetabulum. Anytime the pelvis starts to shift on you, that's going to mean that you've exceeded hip flexion and now that whole pelvic girdle is moving. Okay, so the minute ASS starts moving, or you see a bunch more wrinkles in the shirt, or sort of the pelvis lifts off the mat, back it off. See if you can just see how much just hip flexion they have. I guess that's an important point here. I'm going to do this passively, especially if I'm doing a supine assessment. If it's sitting, I might have the client actually do it actively for me. Okay, well, again, we'll run through that. Here's little Wyatt. He had plenty of range of motion, hips. Okay. Sometimes it's going to be very difficult to find those bony landmarks. Okay. If you can't find the bony landmarks, use the clues that are offered. Is their head really far off the mat? Is there, a big arch underneath their spine? Or now is their back fully engaged? Are there more wrinkles in the shirt? Here, so for some of our bariatric clients, it's going to be more of a mechanical stop. Her belly is going to stop her before any sort of range of motion at her bones. Okay, so just see what kind of range of motion she might have before you get squishing of that soft tissue, and therefore some heat, maceration, bacteria problems there. Okay. And then you'll move from hip flexion to knee extension. That's your hamstring range. Remember, keep the hip in the amount of flexion you want them to sit in, and then extend that leg. Okay, again, any movement that's happening at the pelvis, you're pulling on the pelvis end, you've exceeded the hamstring range of motion. Back it off, because if you proceed and give them sort of 70-degree hangers, all you're going to do is pull that client out of the chair. They don't have the hamstring range. You need to appreciate where that body can be in space. And again, just a nice picture, somebody that has plenty of range, holding up that non-tested leg as well. And then finally, dorsiflexion, plantar flexion. You may pick up some tone here if you have somebody with a neurologic insult. Let that sort of reduce, give that gastroc a bit of a stretch to get more range after that's relaxed. Keep your hip in the amount of flexion that you want. Try and keep your knee in the amount of extension that you're going to put the chair in, because remember that gastrocnemius is also another two-joint muscle part of it. Okay, and because we want to have good weight bearing onto the feet, doesn't really count if you get a lot of dorsiflexion with a bunch of inversion or eversion, because then you're going to get weight bearing on the side on some bony prominences that probably can't tolerate that weight. And then step 3, we're going to take all this back into sitting and back into gravity. We're going to look at those asymmetries, either that we saw in step 1 and step 2, or if we skipped step 2, we're going to see, hey, is that stuff that we found in their wheelchair still represented here? Probably most likely it is, but you may be surprised. Look at their sitting balance. Do they have static balance? Do they need to prop with their arms? They're holding on for dear life. Do they have dynamic balance? When you're looking at their dynamic balance, do they lose their posture? Do they have a postural tendency towards, sort of sacral sitting or heavier on one side? And that's going to give you an indication of where their posture is going to go to. Okay. Confirm anything that you've found in supine or in their wheelchair. If you saw pelvic obliquity, do you still see it? If you saw a pelvic obliquity that could be reduced, can you still reduce it here? Scoliosis, that sort of thing. This is where we'll also look at their range of motion for their lower limbs if we haven't done the step 2. Again, I'll show you that in a moment. And then this is where we'll try and correct any of those asymmetries that we think are reducible. So for Wyatt, we saw him in supine. He is completely reducible, thankfully. So we're just going to put some bolsters, some pelvic obliquity buildups, some rolled up towels, whatever, underneath that low side. And for him, it's pretty significant, right? So we're going to have to boost that up quite a bit. And then once you boost up that low side, then address the scoliosis, because that curve here, it's nice and low, but that curve is really going to shift once our pelvis is more stabilized. Okay. Well, also here you can see that rotation now. That'll be a fore aft sort of reduction that typically I'll do after reducing the pelvic obliquity. And also look at their posture. You can see he's posteriorly rotated, a little bit of a just a rounded spine. You could call it a kyphosis if you wanted to, and resulting in a really forward head. We want him to be a full-time wheelchair propeller. That's not going to be great for shoulder. So we want to get him out of that flexion collapse sort of tendency and into a more upright, more extension, thoracic extension especially. Okay. We'd also love that he didn't have to hold on to the mat. So we're going to have to give him some stability. Okay. But here we go, starting to reduce his obliquity. Here she's just feeling for how much pressure is there. Mom's helping us out, providing lateral support about where those thoracic supports will need to go, and then looking at his dynamic balance. Okay. In this next step, we'll really want to look at where we want to provide the supports. Okay, think about the amount of pressure that you might be putting through. Remember, it's a pressure distribution sort of issue. We want to support in all 3 dimensions so that we can create that nice, safe, functional, comfortable posture. Remember that our hands can force modulate, we can adjust, we can curve, whereas a lot of our lateral supports are foam and ply, and it's hard to force modulate like our hands can. Okay, so don't expect too much out of those lateral positioners. That's what I mean by considering the force and the direction of force required to sort of create those reductions or those postures. We'll show you here in a moment our mat table, but this is a really nice example. I think it's great if you have 2 people to do this part of the assessment. You can have the person at the back creating trunk stability, creating maybe some neutral pelvis, influencing that pelvis, and then the person in front is looking at the spine, looking at the head position, creating a little bit of comfort, safety for the client. Here we've had a high-low table that didn't go quite low enough. Make sure that you're supporting the feet. That's going to get them grounded and sort of get proprioception for where they are in space. It's very important. Start at the pelvis, move up that biomechanical chain. And just a couple examples before we go to the mat. Here's a right-sided pelvic obliquity that we've decided is reducible. We're going to just add a towel underneath here, get that pelvis level, and then figure out where the pads, where the support might need to be for the scoliosis. Start at the pelvis, move up that biomechanical chain. Okay, here's Wyatt again. Here we can see he's quite a bit more level, and look at how straight his trunk can get. Simulate using your hands, using foam pieces, using towels, whatever you have. Should really be doing this even with our littlies. because we're so invested in creating good symmetric postures when they're little. Here, just figuring out sort of what body shapes, what postures are available. And for him in particular, it's kicking up some tone, a little bit at ATNR reflexes. So just again, thinking of that postural tendency. What do you need to avoid? And remember the goals. What we're trying to create is a functional, comfortable posture that's easy enough to get into, yeah, that's protecting the skin, and that's protecting the physiological functioning. We're not looking for perfect. You can see here he's still a little bit oblique. He's a little bit rotated, but I'm happy with that if the skin is fine, if his function is good, because then it gives me this really nice midline trunk position, and then he can use his arms for function. Okay, so remember what our goals are. Here's our guy with the really short limbs, stroke. Said sort of hurdle number 1 was range of motion in his hips. Hurdle number 2 was trying to create enough trunk stability so they could move around a wheelchair. So don't forget that aspect as well. And with posterior support, a pretty good pressure relieving cushion and a high backrest that gave him a hug. He actually has enough stability to at least give a shot to pushing that one-arm drive chair that he had used in the past. Okay. Or if that, beyond that, if that's too much for him to do, could we try doing a power add-on in iExpress, or maybe even a power wheelchair, because now we have a hand that's functional, we have good trunk stability. Okay, before we shift to the camera, I'll just pop in here. Think about when you're doing your assessment that their demographics, their diagnosis, their age, their weight, their comorbidities are all really important in this process. It's going to give you sort of an idea of what the future might hold. You know, I sort of know if somebody has MS, I have either a slow or not so slow reduction in their abilities and their functionality. I think there might be some cognitive things that come up as their disease progresses. So it gives you an eye on what to expect in the future. Think about comorbidities that would impact the important stuff, like things that are reducing their ability to oxygenate the tissue. So if they have cardiac issues or respiratory issues or diabetes issues, because that's going to affect skin integrity and strength. If they have a comorbidity that's a safety issue, like seizures, blackouts, that sort of thing. I also want to know about anything that might affect their weight, their shape, and their tone, because that's going to affect their posture. So are they on steroids? Big weight gain is expected. Are they on some drugs where their appetite is going down, so they're going to lose a ton of weight? Is there some thought that they're going to get a feeding tube placed? Okay, so those sorts of things that might change how the client is in the future. Take a look at medications as well, sort of same idea. I'm most interested in medications that are going to change their size or their shape. That's going to affect their spasticity, their posture. Also anything that's going to change their ability to carry oxygen. Special needs, this is the stuff that can sort of trip us up along the way. Hey, where do I put my phone? Hey, where do I put my communication device? Hey, my bag of shopping needs to go in the back. My backpack needs to come along. I need to have a suction unit or my tube feed come along with me. So I get a picture of what this client is doing, what needs to come with them, what needs to be mounted onto the chair as well. Always good to know what's happened surgically, both in the past and in the future. Anything that's going to change their shape, their size is really good to know before you prescribe that big wheelchair that can't be adjusted. And then your general assessment in terms of their strength, their tone, again, range of motion we covered in the postural assessment. It's important to know what they feel so that you can figure out maybe their postures. We also know that a decrease in sensation is going to put them in a higher risk category for skin integrity. Talked about before in that step 2, take a look at their skin. They may not know what's going on. They may not know there's this area that's red, rough, or sort of brownish. that's a grade 1 skin injury, right? So just take a look so that nobody's missing. There's not something going on that we didn't know about. Remember that there's a lot of stuff going on underneath the skin that's happening before it actually breaks to the surface where we can see it. Think about their cognition, their ability to gain new skills, to use those skills in new environments. Do they have behavior issues that we need to think about? Do they have judgment, safety awareness issues that we need to consider? Visual limitations, safety issues, mobility issues. I also think that visual or cortical sort of vision impairments might be really affecting posture. So if you're not sure, maybe get a speech or OT involved, and maybe they can just give a quick screen, make sure you know what they're seeing and maybe what they're not. And then where do they expect to use the chair? What environments, what sort of distances? I like to ask real practical questions. What steps are you going to encounter? What kind of inclines, declines are you going to encounter? What's the narrowest thing you need to get in between? The narrowest thing you need to get underneath? How are you going to manage inside, outside? What kind of trains do you envision themselves going? Remember, their world might have gotten really small, so don't think about the potential of what they might have if they had a better wheelchair, better assistive technology. And then we also have to figure out how this thing is going to be transported. Are they going to use it in the community? They're going to use it in the community. How are they going to transport it? Do they anticipate that they're going to ride in it, or that they're going to fold it up and put it into the car? Are they going to do it? Is their family member going to do it? Okay, all that sort of stuff. What space, what sort of strategy are they going to use? Who's going to do it? And then sort of a functional assessment. How are they going to push it? How are they going to transfer? Are they going to move it? All that sort of stuff. It goes back to your sort of physical assessment as well. Okay. And then, just asking those practical questions about where do you want to use it? Where do you envision using it? What kind of distances? In what settings? Because each of these assistive devices is really individual for the client that's using it. Some people may use it all day long for their just indoor mobility, or some might be using it almost like a car, really using it across multiple environments and across even urban environments. We just want to make sure that we're getting the right tool for the job. So this, may not be the right tool for the job, but people have things to do. I love that picture. It just shows that people have things to do. So we need to make sure that we're asking the right questions so that we can figure out what they might do, what they might like to do, so that we can, provide the right device, make it all possible. Whether they're on urban sidewalks or they're needing something to get down to the beach. Okay, we'll do a quick shift here and we'll come to just the camera. So Tilly, if you'll come screen. Everybody say hello to Tilly. She said hello before.
Hi, everyone.
And then Louise, you're just going to make sure that if we get crazy with the camera, that she'll, why don't you pop into screen too, just for giggles. Louise has popped in the room. I don't know if you saw her before, but Louise is part of our clinical hub team and just making sure that we're all good on the camera.
Hi, everyone.
Okay, so Tilly, the first thing you're going to do during your supine assessment is if you see a really, an asymmetry, pelvic obliquity with a scoliosis, okay, you're just going to try and correct that. And it's hard for you to see because we're sort of in a different plane, but she's got a pelvic obliquity. So I'm just going to try and reduce that a little bit. Okay, we'll let the camera catch up to us. And what I want to do is make sure that if I can move this pelvis, that I don't create a big fat curve at her trunk somewhere else. And go way that far if you can. Yeah. So if I'm moving her pelvis and all of a sudden she's getting sort of the opposite rotation at her trunk or curve at her trunk, you don't necessarily want to do that. So look, see what else is happening above, even below that pelvis. Again, we could see her movement here. We can now see that her shoulders are not level, but I could also see that I've got a bunch more wrinkles in her shirt. That's telling me that there's some movement that happened at that trunk. So we don't want that. I'll move her back and then give me that obliquity again. Okay. So now we'll say she's reducible. I'm just gonna sort of de-obliquify that. I'm pulling down on the high side and pulling up on the low side. If I can, I've got some good palpation skills and she's not too big and culturally it's okay, I might try and find her ASISs. Go about where you think they should be, and then I'm just going to go down below it and you can find sort of the hook of that ASIS. And what we should find is, what we'd like is that they're the same this way and they're the same in that dimension. Okay, just give a little bit of a look-see. The next thing will be sort of posterior anterior dimension. Give me a big anterior rotation. You're going to know it's an anterior rotation if you have a big gap behind her back. Yeah, round, no wrinkles in her shirt. Okay. What I'll do is I'll just try and reduce that. Okay, I'm pulling the opposite way. May or may not move, but just see how she goes. If you've got a big posterior rotation, you'll probably notice that because her head will be up off of the ground, her mid-back will be completely on the mat. Now I want to create the opposite of that. Well, now I want to go the opposite way and pull the back of the pelvis up. Okay, just seeing how much movement is there. Make sure you're looking at the effects on her trunk. We don't want to make a bigger curve there or a lot of spasticity there or worse head position. Okay, if she also looks very worried or says, ouch, that hurts, remember we're trying to find a very comfortable, sustainable sort of posture. Okay. For me, we're pretty good. We're relatively level. Yeah, so the next thing I want to do is look at her range of motion. Okay. So I'm going to keep this leg bent, and then I'm just going to take a look-see. I might keep my hand on her pelvis here, just so that I can feel when it starts to move. And I'm just going to look for hip flexion. Remember that most of our chairs are 90 degrees at that seat to back angle. So I want to see whether she can go 90 degrees. If I get to 90, less than that, 60, 70 degrees here, and all of a sudden I get a real opposite way, go flat, I get a big lifting of the pelvis, flattening, sort of rounding of the back. That means I don't have that amount of hip flexion. I'm making her whole pelvis come with me. Relax. Okay. Do that one more time. I'm coming up and all of a sudden I get a bunch of that movement, or relax again. And then a lateral curve. If all of a sudden I'm flexing and she laterally, you get a bunch of movement here, wrinkling in her shirt, probably means same thing. You've run out of hip flexion and the whole pelvis is moving. You don't want that, because that's what's going to end up in the chair, right? You're going to have a real obliquity or a real rounding of the pelvis. Okay. But again, we got pretty good range of motion here. And you can see I'm just hooking her calf in the crook of my elbow. So it's nice and easy for me to do. And then I might look at external rotation while I'm here, internal rotation. Also, if you get hip flexion, and the only way you get hip flexion is a bunch of external rotation, well, that doesn't work either, because now where am I going to put my foot plate? Okay, so we just want to make sure that we're getting that hip flexion in that plane only. Okay. Next will be a little bit of abduction, adduction. I just want it midline. Okay. But if I can't, I just need to know how wide that chair needs to be. Now, keep that hip there. I'm going to switch hands, and I'm just going to look at basically her hamstring range of motion. Okay. Don't let that hip come out of the flexion, because that's where she's going to sit. Now we need to know how long those hamstrings are. We need 70 degrees for most wheelchairs. But if I get to, say, all the way here, and then all of a sudden that pelvis starts to move on me, again, I don't have the range in those hamstrings, so I'm going to have to accommodate with my wheelchair for that foot being closer into the system. Okay. Good to just check that really quick. And then, then I'll change my hands. Keep the hip there, keep the knee there. Now look at dorsiflexion. Again, you might create some tone. Yeah, just like that. See if it reduces. If all of a sudden we get a bunch of inversion when I bring it into dorsiflexion, all of a sudden now she's going to have really a lot of pressure on her foot plate on that lateral edge of her shoe. I don't want that. Okay, so see how much you have just in that normal or that single plane of plantar flexion, dorsiflexion. And if you don't have it, well then we can just have angle adjustable foot plates so that we can accommodate it. I won't do both sides, just because my body will be in the way of the video, but obviously I would do the exact same thing on the other side. While she's here, might be a very good time to look at her skin. Just, hey, can I look at your skin? Is there anything going on? And then just drop the drawers a little bit, open up the shirt to see what might be going on. It's also a good time to look at strength in the arms, not against gravity if you're worried about her strength, and also just look at shoulder mobility. So can you do a snow angel for me? Probably a bad reference in Australia. Okay, can you come to the middle? Okay, can you come out to the side and up? Just really quick, a screen, right? To look at how those upper limbs are functioning. If she can move by herself, I probably won't go near a supine assessment. I'll just start at sitting, okay? Because she's just gonna have more control than that. Okay, step 3, or if we skip the step, it's gonna be the sitting. So if you'll face towards the camera, and let's say you didn't have to do step 2. You're here because she's only using a wheelchair part-time or just less complex posture. First thing I'm probably going to do is look at her balance. Can she sit unsupported, or am I having to hold on? Is she propping? Is she posteriorly propping or anteriorly propping, whatever? And what does her posture look like? Give me a real slouch. Obviously, she needs quite a bit of support. It should probably be propping at that edge too. Okay, and then can she fix that posture? Be a little bit low, thank you. Can she self-correct? Hey Tilly, can you sit more upright? And what does that look like? If she can correct, then look towards dynamic balance. Hey Tilly, can you touch the top of your head? And what does that postural tendency look like? She might really drop like a pelvic obliquity or lean one side or go posteriorly like that. Yeah. And then, hey, can you reach out of your base of support? This is a really good one to ever sort of reach forward and maybe touch me. What happens to that postural tendency? Does she lose it, or does she sort of go really heavy on one side? Just seeing what her capabilities are. Next, probably what I'll do, I'm still your cushion again, is just do a really quick screen of range of motion. I tend to do it by functional movements. So hey Tilly, can you do some marching for me? That's going to get you past 90 degrees. So that's a really quick way to look, hey, do you have 90 degrees at both? If she can't get up on one side, then I might passively do it. Also, if she can't get up on one side, are we getting some asymmetries with her posture as well? Okay, so that's going to be hip flexion. If she's sitting really frog-legged, hey Tilly, can you bring that in? What kind of movement do we have here? And then the next will be just like extensions. That's going to give you a really good indication of what hamstring range is. Also, again, a nice look of dynamic balance, any tone issues. And then last one, toe taps and heel rises. Hard when you're throwing on the mat. Okay, so just a really good screen. Obviously, I'm not helping her with her posture. If she's a little bit more unstable than that, I'd be closer, obviously. Okay, and then either way, if you've done step 2 or step 3, because if you've done step 2, next thing we want to do is manage any of those asymmetries that we saw. Bless you. Tilly, let's do a little pretend. Let's go a pelvic obliquity on the left-hand side. Okay, so hopefully you can see that. Step away a little bit. She's low on this side. Either I know because I've done the supine assessment that it's reducible, or I want to try it here. I'll get some fancy wedges. We've got the J box and some spinal line pieces from J. Sneak that underneath the low side and see if you straighten out. Again, you can look for your bony landmarks. Look for her iliac crest or even her PSIS back here, or just look, hey, what happened with her trunk? Always ask permission, but it's also really good to just sneak up that shirt and see what kind of spinal curves you might be getting. That was a pretty big one. That was a 1-inch pelvic obliquity buildup, maybe too much. I can maybe try a 1/2 inch. This is the J obliquity 1-inch buildup, or that's a 1/2. Or we could use little bean bags or little pieces of foam or towels, whatever. But try, if you think it's reducible, try and build up underneath that low side. If we also had a rotation, go forward on the left. Yep. Forward on the left, if we think that that's reducible, we're just going to try and pull it back on the forward side and give it a little bit of a push forward on the opposite. So here, I've got my hands going like this. Can we reduce that? If we can, great, but make sure that we haven't created any more curves worsening at the spine or taking away her function, taking away her balance. Make sure you're still considering all of that. Let's look at scoliosis here before we just shift in the camera. Always start, even if you've got a big scoliosis, always start at the pelvis, because that pelvic position is probably the root cause. And when you reduce that, it's really going to change the spine alignment up on your trunk. Okay, so we've altered her pelvis there, and now we still have a bit of a curve. Let's give him a big curve, just so it's hard to see. Okay, hopefully you can see I've got a big curve here. Find the apex of that new curve, and you're going to give some support. And then for adult clients, we're probably going to go higher on the opposite side and move in. So we're going to correct. Basically, I'm coming in with my hands at the apex of the curve, and then a support higher up on the opposite side. We also may want to do a little bit of a support here for that 3 points of control idea. And I can either have my assistant that's helping, or I could use a little bit of my own leg here to just create that 3rd point of control. Hopefully you can see my brown leg coming in and giving me that support. Okay, the whole idea here is we're trying to figure out where the placement of the lateral bits need to be, how big or maybe how little, and sort of what the curve of them needs to be, size in terms of height and in depth. Okay, so that then we can, we're just simulating here. We can then translate that into a chair with a backrest and a set of laterals. See how that actually works when I get them into the chair. This whole process just allows us to get that trial chair in a better position so we can pop them right in and, hey, that works quite well, or just need to move that lateral down a little bit. It's not a big process. Okay, obviously if we then were to move up the biomechanical chain, the next place that I would go would be the head. Pretend you're Tebow with my really bad head position and back. Okay, so we've already sorted out his trunk, hopefully. Next place I'm gonna go is I'm gonna try and sort of correct that head position. It works the same way. We're gonna give sort of lateral supports. Remember, the places that we can offer support is suboccipitally, below the ears, occipitally, so the bump in the back of your head, and then temporal if you need even more support, and the frontal. Got to keep it away from the ears, got to keep it away from the jaw, got to keep it away from the eyeballs. Okay, but the same process will work. If you see a big, we'll go the same direction. If you see a big lateral curve with extension, you're going to want to try and correct it going forward and offer the support to correct the lateral. So I'll do the lateral side first, and then also just really looking towards occipitally and suboccipitally, trying to sort of scoop and create a more midline head position. Okay, this is when it gets really good to have 4 hands, 2 people. One person can be working the pelvis and the trunk, and then you've got another set of hands that will help with the head position. Okay, so that's sort of from the frontal view here. If you spin to the end, and then let me just make sure we can. I have a great client, she brings her own footstool. Okay, so now let's say we had a posterior pelvic tilt that we knew was correctable. Even though this is a big curve, really the cause of it is all the way down in the pelvis. So can you reduce that? And I'm giving pressure at the sacrum, at that PS, sort of right across from the PSIS. I can either do it with my hand here, or I might even sort of sneak on board and have it happen with my knees. That's too much. You can put some padding in between, like a pillow or a couple towels. If you're a little bit low too, you could raise yourself up and have your knees come a little bit higher on the PSIS. And you can sort of play around with how much support she needs, posterior, anterior. If we think about that rotation we saw before, okay, we have forward on the right, back on the left. Now we can sort of do that D rotation here. You can see what I'm doing. This hand will give a little bit of a forward, and this one will come back. And just trying to get that into neutral if she can. And then the back support. So stabilize, and then Doug, post your top for me. Let's say we've got this, but we know that it's reducible, and we don't want it to sit like that for all the bad things it does to skin integrity and pulmonary system. So I'm going to come back to neutral, give a little bit of support, and then I can also figure out where I need that back support to be. Does it need to be, pretty high? She doesn't have great trunk support. We're going to put her in a tilting space, so it really needs to be almost near shoulder height. Or she's going to be in an active manual chair, so I'd really like it to be below those scapula. I'm just putting my hands on, trying to figure out what height is required, and also maybe what shape is required. You'll feel it once you get sort of her trunk balance. She'll sort of fall into your hands, and you can feel that she's stable. Then you might test her balance a little bit. Hey, Tilly, can you put your hands on your head? Okay. Oh boy, back need to be a little bit higher. All right. Or need a little bit more lateral support because I saw that postural tendency where she really started to lean one way or the other. Okay. So here are my hands. I'm trying to figure out, hey, what height of back do I want to trial? What shape of back do I want to trial? What angle? So she's really upright now. Well, maybe I want to have a little bit more of a relaxed posture. Maybe a little bit more, a more relaxed posture. So do I want to put a little bit of back angle into that thing when I actually try her in a wheelchair? Okay. So back height, back shape, back angle. And then if you knew that you wanted to add some shaping to the backrest, you could put your hands on and figure out what height it needed to be, what sort of depth it needed to be, what angle and what width it needed to be. All simulating so that we can then, put the backrest on the chair that we want to try, the cushion, and have that trial go much, much quicker. Okay. Anything else here? Maybe show just a little bit in terms of the head position. So we went up, sort of the pelvis, the trunk, and then where does that head support need to be? Give me an extension. It's probably going to be the easiest to see. Okay, if I want to get her out of that posture, just give a little bit here. Suboccipitally, even occipitally. Where does that pressure need to be? And then this is a great place to take some measurements too. So you're going to know, hey, I need a headrest that's going to be about that height from her seated position. I want a back height that's about that height from her seated position. I need my laterals at that height from her seated position. So again, you can get those dimensions and you can set up your trial chair. So you're just a little bit more ready, a little bit more prepared. She's going to feel safer when she gets into that chair. And maybe you have fewer transfers back and forth. Okay. Anything to add there, Miss Tilly?
No, I think you covered it.
Okay.
Get on, have a feel, and, trust yourself, I think.
Yeah, absolutely. You can see so much from getting somebody out of their wheelchair. So many postures might be because of the wheelchair, right? Like that's sort of forcing them to sit that way. So get them out. If you don't do the supine assessment, that's okay, especially for your not so complicated postures. But just getting them out onto a flat surface, a more firm surface, even a kitchen chair, it's safe. So you can see sort of what the availabilities are of range of motion, of balance control. Just helps the whole assessment process. Might feel like more work, but I think in the end, it's actually makes the whole process more successful and quicker. Okay. Sorry about my goof in the beginning. I apologize. It's Friday. Is it Friday the 13th?
It feels like it today.
Apologize. My fault. We'll see you next time.
See you
Bye.
guys.
You just go to that red arrow and click that X.